Today's lecture, COVID-19 and Oncology Practice, with Stephen Kimani, MD, MSc. We're thrilled to have him here today. Dr. Kimani is a board-certified internal medicine physician and current third-year fellow in hematology oncology at the University of North Carolina at Chapel Hill. He has spent a great part of the past decade training and practicing medicine in various settings around the world, including Kenya, Tanzania, South Africa, Malawi, and the USA. Prior to joining UNC, he completed a Master of Science in Global Health and Internal Medicine residency at Duke. At the beginning of the COVID-19 pandemic, Dr. Kimani was involved in a multi-institutional education collaboration across the U.S. Through which emerging knowledge regarding priority issues on COVID-19 and oncology care was reviewed and rapidly disseminated. Through this innovative platform, he was able to leverage collective learning from national experts on key issues regarding this novel infection. Dr. Kimani, welcome. We are so glad to have you here today.
Thank you, Tim. Welcome, everyone. And, when I was asked to give this talk, this was last year in the fall, I was optimistic, cautiously so, that by the time I was giving this talk in March, we'll have some excitement to talk about vaccines. And so I'm glad that we have...
they did have a small banana.
I'm sorry, we just had Dogwood join. Let me just... All right, sorry about that. We've muted them. Go ahead, Dr. Kimani.
Yeah, so I'm glad that we are having this talk in March when we can talk a little bit more about the advancements over the past year and a few months. So maybe we can move to the next slide, Tim.
Sure. And let me ask you, Dr. Kimani, what's one thing we should know about you outside of your professional bio there?
Well, I am relatively well-traveled, and you are likely going to find me in the woods, hiking as much as you're going to find me in clinic.
Right. Good to know. I hope to see you out there sometime. I'm the same. So, this is our poll everywhere question. Again, it's anonymous. This is just a screenshot of it. I think this is a softball for all of you. COVID-19 has no impact on cancer care. If you think that's true, A. If you think that's B, false. And while our audience is thinking about that, I will read our disclosures. This activity has been planned and implemented under the sole supervision of the course directors in association with the UNC Office of Continuing Professional Development. William A. Wood, MD, MPH, and CPD staff have no relevant financial relationships or commercial interests as defined by the ACCME. Stephen Kimani, MD, MSc, has no financial relationships with commercial interests as defined by the ACCME. And let's take a look at that first poll everywhere question. We seem to be running pretty strongly in the direction that that's a false. How are they doing so far, Dr. Kimani?
They're doing excellent.
Good, good. All right. So without further ado, COVID-19 and oncology practice, and I'll turn it over to you.
Next slide, please. Next slide. So I have a few disclaimers about this talk. First of all, that COVID-19 is a quickly evolving situation. And even while preparing these slides, I was coming across new emerging information that was changing something I thought previously was established. So this talk will highlight data supported by peer-reviewed publications. In one or two instances, I will talk about pre-printed publications that have not yet been peer-reviewed, but I think are important for people to know. In that case, I will make sure I highlight that. And then issues specific to bone marrow transplant or CAR-T population patients, as well as other advanced immunotherapy approaches, will not be covered in detail in this talk. Next slide. So when thinking about this talk, I acknowledge that the rapidly expanding COVID-19 respiratory pandemic has impacted all areas of daily life, and this is both for medical care, for social lifestyle, economic lifestyle as well. there have been important considerations to slow disease spread, as well as to improve and continue delivering care for cancer patients with cancer as much as we can during this crisis. Several questions that came to mind when I was putting together this talk is as shown in the slide, specifically wanting to know which patients with cancer are at the greatest risk of COVID-19 infection. What are some of the complications and outcomes of COVID-19 among patients with cancer? And then any specific treatment, best treatment and management situations in this population. We also wanted to talk about how the available COVID-19 vaccines compare and what we know about vaccines in patients with cancer. Highlight one or two issues that are emerging as major post-vaccination things to watch out for as we rapidly scaling up vaccination efforts. And then the last two questions are mostly about what to do about anti-cancer or cancer-directed treatment during this pandemic, and then how oncology practice should adopt. Next slide, please. So there you'll see I've outlined 3 key objectives, which again go over the epidemiology, the vaccination efforts, and then the cancer care delivery. Next slide. So in this slide, I'm hoping that you're able to see that the COVID-19 pandemic has been evolving over the last year. Team, I think this slide is supposed to have a play.
And we are playing that, so you can see the evolution of that.
Excellent. So this is just to show the increase in the number of cases globally since the case was first described in China in December, but mostly since it was recognized as initially as an epidemic and then as a pandemic between January and March of 2020. And as you can see, 3 months later, we are having almost all countries in the world touched by this COVID-19 pandemic. Next slide. So a quick overview of the virus itself. So this is the SARS-CoV-2, which has caused the disease known as COVID-19. There are a couple of things to remember. One is that there are 2 main processes that are thought to drive the pathogenesis of this virus. One is that infection with the virus that leads to incorporation into host cells leads to rapid viral replication. And that rapid viral replication is associated with cellular damage. The second mechanism is usually with viral infections, there's a profound inflammatory response, typically through both B cells, but also T cells, so cytotoxic T cells. And this hyper-inflammatory response to the virus leads to tissue damage. We know that the SARS-CoV-2 specific antibodies and cell-mediated responses are also induced following the infection. Some of these antibodies have neutralizing capacity and some do not. And also we know that some of these antibodies can have antigen-dependent effect on the organs that have been infected. The duration of these protective effects from the neutralizing antibodies remains unknown, and that's something that folks are looking at. Risk of transmission, so this is a respiratory pathogen, so risk of transmission depends on the exposure. We know that close contact in closed spaces has the highest risk of transmission, as opposed to distant contact in open spaces, hence the recommendations for the physical distancing. Since the pandemic started, we've noticed typical of many viral pathogens is that as there's always that fitness to survive at an organic level, they will mutate over time. And right now we have notable variants as the UK variant of the B117, and then the South African variant as the B1351, and then the Brazilian variant as P1. Some of these mutations associated with unfavorable outcomes are thought to be more profoundly transmissible. That specifically has been cited as for the UK and the South African variant. And then in terms of severity of illness, it's been cited as South African and Brazilian variant. Next slide. Cancer patients who have cancer or have been treated for cancer in the past have a higher risk, are historically considered to be at high risk for infections. We know that during cancer itself, you can actually have bone marrow invasion or bone marrow suppression, and this can cause immunosuppression. We know some of the cancer-directed therapies, such as chemotherapy, can induce myelosuppression or bone marrow suppression, as well as other cellular elements of immunity. Folks who either have cancer or have been treated for cancer or are recovering from cancer typically also might have poor nutritional status due to the extensive cachexia that comes with advanced cancer, but also due to limited nutritional effort during treatment. This might lead to decreased performance status, independent sometimes of pure nutritional status, and also cause fragility, mostly as an element of what I've mentioned before, but also other issues like high comorbid burden and advanced age. Patients with cancer tend to have frequent exposure or interaction to healthcare, typically in the sense of frequent visits to the cancer clinic or for infusions or admissions or trips to the ED, and this also places them at high risk for infection. Next slide. So COVID-19 is not expected to be different. You know that a few observational studies have demonstrated that patients with cancer are at higher risk of COVID-19. This seems to be variable, but relatively high incidence compared to the general population. There was a study that came out of China in looking at infection among cancer patients, COVID-19 infections among cancer patients in one hospital in China. This was December and January, and this showed almost 30% rate of infection compared to non-cancer patients. Other subsequent studies have confirmed these findings, including in the US and other places in the world. The risk factor seems to be older age in this population, male sex, black race, as you've had a lot of talks about disparities, Hispanic ethnicity, poor performance status, recent cancer diagnosis, and comorbidities. The risk of infection seems to be highest for lung cancer patients. And this also includes patients, this might also include patients who have metastatic, other primary cancers with metastasis to the lung. This was cited from a sarcoma study, as well as patients with hematologic malignancies. For example, the odds of infection were highest for if you had a recently diagnosed leukemia, your odds of infection with COVID-19 is about 12 times compared to no cancer diagnosis. And for lung cancer is about 7 times. The incidence rates of cases of COVID-19, just like in the general population, have also been variable during the different phases of the pandemic. Obviously, when there's a higher rate of community transmission, there's also a higher incidence among at-risk population, and that we've seen that looking at spring 2020 and fall 2020, where there was about a twofold increase in the incidence rate. Go to the next slide. Cancer is associated with worse clinical prognosis, clinical outcomes among patients with COVID-19. This has been shown, again, at this point you have to recognize that a lot of our data comes from observational cohort studies as well as single center descriptive studies. So this is not the most robust data, but a lot of these findings are being shown from different sites and different approaches. what we know is that cancer patients are likely to have more severe illness and death. In one particular recent publication that just came out maybe a few weeks ago from the Cancer Consortium, COVID-19 and Cancer Consortium, CC19, showed that patients with cancer and COVID-19 have a mortality of about 15%. And comparing that to patients with COVID-19 without cancer, which is 5%, and then patients with cancer without COVID-19 is 4%. So you can see it's a pretty high rate of mortality. Some of the outcomes, we've already looked at increased risk of infection. I'm telling you there's increased risk of mortality, and the same risk factor seems to play a role here. What's worth noting is that outcomes are improving, and this is just a continuation of the improvement you're seeing with outcomes among a general population. Similar to risk of infection, the mortality risk seems to be highest for lung cancer patients and other thoracic malignancy. And there's a whole thoracic malignancy consortium that is looking at these outcomes. It doesn't, it kind of makes sense that the most involved organ by COVID-19, if you have cancer there or have decreased lung reserve, that you probably have poor outcomes. Next slide. So this slide has two transitions. One is to show that cancer is associated with increased need for ICU and mortality among patients with COVID-19. And Tim, you can just play the animation. So in the first table, this is a meta-analysis that looked at, cancer patients and those patients with cancer as well as patients without cancer, and looking at the risk of intensive care admission. And you can see that the risk is about, the risk ratio is 1.5, and that was the lower boundary of the 95% confidence interval is 1.31, which suggests that, yes, COVID-19 infection in patients with cancer is associated with an increased need for ICU. If you play the next animation, it will bring another table that looks at mortality specifically. And this, again, we are seeing a risk ratio of 1.66 with a lower bound of the 95 confidence interval at 1.33. And what's worth noting is that these were meta-analyses of 32 studies, so 3-2, involving almost 50,000 patients, including 1,800 patients with confirmed cancer, from Asia, a few countries in Asia, Europe, and the US. So I think the signal is pretty strong. Next slide. We know that SARS-CoV-2 virus has an impact on patients' immune system, and that host immune system also play a role in impact of SARS-CoV-2 on outcomes. So there was a study done by Sultan et al. That showed that the majority of solid cancer patients were able to clear their virus and recovered from COVID-19, re-establishing their prior immunological status, in contrast to hematological cancer patients. And some of the postulated differences are shown in this pictogram. You can see that folks with solid tumor tend to have prolonged viral shedding, while patients with hematological cancer seems to have definite prolongation in viral shedding. And you'll see how this is important. Can look at delayed rates of seroconversion following an infection with SARS-CoV-2 among hematological cancer patients, as well as sustained immune dysregulation following viral clearance. So we're already hypothesizing that hematological cancer patients with hematological malignancies might behave differently in terms of their risk and outcomes of COVID-19. Next slide. Another, in the UK, where a lot of observational data has come, and part of it is just they have better integrated data through the health system, so they're able to do natural observation studies. Williamson and Walker published a paper looking at 17 million individuals among whom there were 10,000 deaths from COVID-19, and they did multivariate analysis and isolating patients who had cancer and looking at whether duration of cancer history matters in terms of mortality. And it looks like the longer you've lived or had cancer, probably you're better off than someone who's recently diagnosed. And this difference seems to be also present comparing hematological malignancies versus no cancer. So they did not do a comparison of hematological malignancy versus solid tumor, but you could extrapolate that hematological malignancy had impact on outcomes as well. So in summary, they found that beyond 5 years, the risk of death remained elevated for those with heme malignancies, but not those without with solid tumors. Next slide. We've already talked about that. Next slide. So this is segues nicely into this next slide, which talks about do we know for sure that outcomes are worse? We've looked at observational data that seems to suggest there's a signal there. If you play the animation team, there will be a table that plays. And this is a meta-analysis specifically looking at hematologic malignancy patients. This included data from 34 adult studies and 5 pediatric ones, conducted again in Asia, Europe, and North America, including 400 patients with heme malignancy who had COVID-19. The risk of death among adults was 34% in this sample of predominantly hospitalized patients, and most patients were older than 60 years. And so we can take away from this meta-analysis that hematologic malignancy associated with worse outcomes, even among cancer patients with cancer. So again, the message here is that cancer is very heterogeneous and outcomes are different depending on which cancer you have. Next slide. Switching gears a little bit and talking about the impact of COVID-19 of cancer-directed treatments. So treatments that we're giving our patients to ameliorate their cancer or treat their cancer. Does it have any effect or impact on COVID-19 outcomes? And at this point, I would like to highlight the Cancer Consortium on COVID-19, the CC19 registry, which collected 928 patients from the US, Canada, and Spain with active or previous malignancy who had confirmed as COVID infection. The most prevalent malignancy in this study was breast cancer, again mimicking population epidemiology, and prostate cancer. 43% had active disease. The use of any form of anti-cancer therapy, cytotoxic or non-cytotoxic, within 4 weeks of infection was not associated with a higher 30-day mortality rate. So this was earlier in the pandemic where this study found that there was not necessarily an increased risk associated with cancer-directed therapy. A paper was just published about a week or so ago, again from the same consortium, which seems to suggest that cytotoxic chemotherapy within 30 days is associated with a higher rate of mortality. What I can tell you is that available data linking recent active therapy to poor outcomes, specifically cytotoxic chemotherapy, is really mixed, and therefore it's not very clear-cut which way the axe is going to swing eventually. So stay tuned for that. What we also have seen from other studies is that the type of treatment may influence the risk. So the risk is not equal among cytotoxic chemotherapy, lymphodepleting immunotherapy like anti-CD20, immune checkpoint inhibitors or targeted therapy, or even radiation. Next slide. What we've just talked about is summarizing this pictogram over here. Looking at this meta-analysis, you can also see that the signal towards chemotherapy increasing mortality, but as I mentioned, this depending on the timing and the inclusion of the population, this has been mixed. This is looking at immunotherapy, systematic review on immunotherapy, and it does show that there's probably no impact of immunotherapy on death. Let's talk about COVID-19 and thrombosis, and this is by itself an entire couple of webinars, so I'm not gonna try to cover everything, but a few studies, including one from Massachusetts by one of my colleagues and close friend, Rushad Patel, did find that COVID-19, as we know, is associated with an increased risk of arterial and venous thrombosis. And this has been termed COVID-19 associated hypercoagulable state, but that there's limited evidence that cancer patients, or patients with cancer who develop COVID-19, are at higher risk of this coagulopathy. So obviously these data are limited by observational nature, mostly small single center studies, but a lot more is coming through larger randomized trials, so stay tuned. Next slide. Looking at treatments and clinical outcomes among patients with cancer, I'm gonna say that I will not cover in detail every individual approach to therapy. Instead, I will highlight and point you to guidance available from authorities. A couple of things to take away from this is that baseline COVID-19 severity is strongly associated with the receipt of treatment. So that makes sense, right? So severe COVID-19 infection requiring supplemental oxygen with mechanical ventilation will be treated different from a largely asymptomatic infection. In the era of emerging and rapidly changing data, I think a few things have been established that you can take away from this, that hydroxychloroquine probably has no benefit, and that high-dose corticosteroids alone or in combination with remdesivir show potential benefit, with a few caveats about cancer patients or cancer patients on cancer-directed treatment. Same observational studies that have been citing through the COVID-19 consortium have shown disparities in medication access. Again, we already know that being Black, being male, being of ethnic status does come with the risk of infection as well as mortality, even in cancer patients. Now we are also seeing that there are disparities in medication access, that Black patients with the same level of severe illness are approximately half as likely to receive remdesivir compared to white patients. Now, whether this is because of the geographical effects of where remdesivir was readily available versus not, and issues of healthcare access to these facilities remains to be explored. There is no randomized data yet on treatment and outcomes among cancer patients. Next slide. So this slide is busy, and it's not supposed to, you're not supposed to remember everything that comes out of it. I just wanted to highlight that as of February 11th, again, time point here is relevant. The NIH, through its COVID-19 treatment task force, has established a guidance on how to treat patients. Approved or encouraged treatments include the off-label use of dexamethasone as the high-dose steroid, and this has been recommended for anyone who is hospitalized and requires supplemental oxygen. And this can be used together or without remdesivir. For outpatients, there is a emergency use authorization for some. There are several products with monoclonal antibodies for the spike protein for the SARS-CoV-2. And these are, there are a few names you'll see there. These are approved under EUA for outpatients with mild to moderate COVID-19 and at high risk of progressing to severe disease or hospitalization. So this is where most of our cancer patients with cancer will fall. If you are to see one in clinic who does meet the criteria for high risk progression to severe disease. Obviously, availability remains an issue. What is worth noting is that the the monoclonal antibodies, the combination, they do block the virus from entering into the host cells, and they are thought to have activity even for the UK variant, but they are quite significantly less active against the South African variant. Just as a takeaway message from this slide is to demonstrate the available data showing efficacy of dexamethasone and other steroids. And so you can see that they, pretty much relatively interchangeable, but strongly consistent in favor of dexamethasone. There are a couple of challenges in the care of patients with COVID-19. One, in care of cancer patients with COVID-19, one is that the patients with cancer tend to have profound immunosuppression. And as we've seen a few slides back, regardless of whether solid tumor or heme malignancy, they are likely to shed SARS-CoV-2 viral particles for prolonged periods of time. Obviously, this is higher and more likely in profoundly immunosuppressed patients, including heme malignancies or post-bone marrow transplant or CAR-T patients, or those on active therapy, than cancer survivors who are not on active therapy and their cancer is in remission. There is also risk of immune-related pneumonitis from immune checkpoint inhibitors. And actually, at the beginning of this pandemic, the Society of Immunology, Oncology did write a guidance paper on how to approach patients who are on immune checkpoint inhibitors who present with signs of pneumonitis and test positive for COVID-19. Because as you can imagine, that's a delicate issue to tease apart. High burden of other comorbid condition and limited functional results make it very challenging to take care of patients with cancer who also have COVID-19. At this point, I think, Tim, we have a Paul everywhere question.
We do indeed. So which one of the following statements regarding cancer and mortality from COVID-19 is true? A, cancer patients have a much higher mortality rate from COVID-19. B, cancer patients have a much lower mortality rate from COVID-19. Or C, there is sufficient evidence that treatment with cancer-directed chemotherapy increases mortality from COVID-19. So take just about 10 more seconds if you would. I have a lot of people siding with A and a lot siding with C, so we'll be interested to learn the answer in just a few more seconds. Dr. Kimani, what answer were you looking for here?
Yeah, so, this is one of those questions that probably testing if you're paying attention to what I was saying than what was on the slides. So I was looking for A is the correct response. I think the data that we have so far, even though it's all observational, seems consistent that patients with cancer have a higher mortality rate from COVID-19. The C option, the trick here was there is sufficient evidence. There is not sufficient evidence that treatment with cancer-directed chemotherapy increases mortality. As I said, data here is mixed.
Gotcha. So even with the cytotoxic chemotherapy, there's still a lot of information to be gained.
Correct, because we have several studies at different time points coming to different conclusions. So on one side, I can give you enough studies showing that cytotoxic chemotherapy increases mortality, but at the same time, I can show you the same number of studies, if not more, that shows that that's not the case. So I think what underlies that question is who's receiving cytotoxic chemotherapy during COVID-19 pandemic, and is that likely the moderating effect rather than just receipt or no receipt of chemotherapy?
Interesting. Well, great question, and thank you so much for all the responses. And I'll go ahead and progress the slide.
Yeah. So as we get ready to switch gears to the next topic, wanted to summarize a few things. One is that, back to our questions at the beginning, cancer patients with cancer who seems to be at the greatest risk of infection and death are lung cancer patients, including those with, possibly including those with the lung metastases from other primaries, as well as patients with the hematological malignancies. Some of the complications and outcomes that are established is that there is definitely an increased risk of death. And then in terms of best treatment and management situations, I'll say, you know, the guideline from NIH is dexamethasone plus or minus remdesivir for hospitalized patients requiring supplemental oxygen, and possibly monoclonal antibodies in select outpatient cases. So this, in a nutshell, best treatment and management depends on the setting. Next slide. So moving on to the next objective, which is talking about vaccine. Next slide. I'm going to start with talking with a quick disclaimer that this talk will be limited to only those vaccines that are approved and available in the US. Initially, when I was preparing this talk, I had all the 10 or so vaccines that have made it beyond phase 2 trial, but I realize it's not helpful. Just let's focus on the 3 that are currently in use. The first 2 are the Moderna and the Pfizer-BioNTech vaccine. An interesting story here is that BioNTech actually is an oncology vaccine company. And so they have been working on developing cancer-directed vaccine therapy for years. And this COVID-19 was just an opportune moment for them to test out their mRNA technology towards a global pandemic response. So both of these vaccines, the Pfizer and Moderna, mRNA-based vaccines, they are both given as 2 shots, with the Moderna vaccine separated by 4 weeks and Pfizer separated by 3 weeks. When I prepared these slides, I said approval of studies did not include cancer patients. Now, that's not true, because looking through the publication for the Pfizer vaccine, and hidden in page 12 of the 3rd supplementary material was a table of all the participants, and the Pfizer trial did include about 1,400 cancer patients, almost equally divided in both the intervention and placebo arm. So if you're making notes, note that the Pfizer trial included cancer patients. The description of those patients is, you know, these were only 3% of the trial participants. They were mostly solid tumor patients, with only 7 who were metastatic solid tumor, and only 70 who were either leukemia or lymphoma. So again, going back to that, you know, cancer being a heterogeneous condition, there were cancer patients included in the Pfizer trial. They were most likely going to be solid tumor, non-metastatic, rather than heme malignancy or metastatic. A couple of points about how this vaccine works, just for the interest of those who might not be very familiar, is that we know that an RNA is the minimal genetic vector that is needed to translate and produce protein synthesis, proteins here including antigens. So this technology basically introduces mRNA that has the exact signal for the spike protein, and then which is the most antigenic part of the virus. And this is introduced through a nanoparticle. So this nanoparticle is lipid and it's very unstable. This is what makes these vaccines hard to stop. And once it's incorporated into the cells, it delivers the messenger RNA, and it's a messenger, so it is produced and is expressed by the antigen-presenting cells, and this mimics natural infection. So you end up producing both the desirable humoral and cellular immunity, as well, just as good as if you had a natural infection, without the risk of getting infected. So this mRNA does not cause an infection. It does not integrate with the host genome. And mRNA generally are rapidly cleared by nuclear enzymes. So in the trials that led to the approval, both of these are greater than 90% efficacious. What's worth noting is that at the time these trials were being done, the variants were not yet mainstream, so we don't know the effect, and I'm sure there's new data coming out about that. Next slide. The third vaccine is the Johnson & Johnson, or the Janssen vaccine, and this is uses a different approach. So it's an adenovirus vector vaccine. What's worth knowing is that viral vector vaccines contain a delivery virus, so in this case adenovirus, that has been recombinantly engineered to contain genes encoding the antigens of choice from the target pathogen, in this case the SARS-CoV-2, but do not have the capacity to replicate or cause infection. So they're just using the stable DNA virus, adenovirus, to transport genetic material into the host cells, again mimicking a natural infection. And then once it's there, activates both cellular and humoral immunity. A disadvantage in this type of vaccines is that because you're using a viral vector, you might not necessarily get the benefit of a prime boost strategy, which is usually giving the second shot. And so that's why this was studied as a single shot. This study, the Johnson & Johnson approval studies, included some cancer patients, and because this was also completed in South Africa, they were able to show that 57% efficacy among the South African variant. Next slide. So in this table, I've shown the three available vaccines: the Pfizer, the Moderna, and the Johnson & Johnson, and their schedule. I've summarized the trial participants. So these were large phase 3 studies, mostly in adult patients. And also their endpoint was similar with subtle differences. What's worth noticing is that for the Johnson & Johnson endpoint, clinical trial endpoint, it was prevention of moderate to severe disease, which most people agree that's a more meaningful endpoint. They're all highly effective. What's worth noticing is that for the Pfizer vaccine, you achieve that 95% efficacy at least 7 days after dose number 2. For the Moderna, it's at least 14 days after dose number 2. And then for Johnson & Johnson, it's about 28 days after a single dose. And also that the Johnson & Johnson was efficacious against the South African variant at 57%. Other vaccines in the pipeline, you've heard about AstraZeneca Oxford. That's again a viral vector vaccine. It's a 2-shot vaccine. And then Novavax is producing a spike protein subunit vaccine that uses an adjuvant protein for sensitization. Next slide. Important considerations on vaccine safety and efficacy in cancer patients is that response cannot and should not be assumed. This is because what we know about vaccine response and specifically patients with cancer is that the response, seroconversion is highly variable. We know this from a seasonal flu vaccine, a hepatitis B vaccine, meningococcal subunit vaccine, and even the diphtheria and tetanus toxoid vaccines. In these examples, rates could be as low as 30% among cancer patients with cancer compared to immunocompetent patients. And this blunted seroconversion is actually greater in heme versus non-heme patients. So the concept of net immunosuppression is actually applicable here, which is looking at the cancer, the treatment, the host, and the infection. And depending which way the axe swings, you could either be net severely immunosuppressed or barely immunosuppressed. And that's what I think we need to remember about patients with cancer. As of now, eligible individuals with an immunocompromising condition, including cancer, can receive COVID-19 vaccine, and this has been supported by professional organizations like the Nccn guidelines and ASCO. Next slide. So we're getting close to the end here. So we have a poll everywhere question. Tim?
Sure. And so which one of the following statements about COVID-19 vaccines in cancer patients is true? Operative word true. A, none of the vaccine studies included cancer patients. B, all of the vaccines have been shown in studies to have no side effects for cancer patients. C, vaccine efficacy cannot be assumed in immunocompromised patients. And we'll wait about 5 more seconds, but already I see everyone very solidly answering that vaccine efficacy and response cannot be assumed in immunocompromised patients. How did they do?
Wonderful. This is true.
Good.
And you can move to the next slide.
All right.
So I thought I had a summary slide at the end of this, but quick caveat or additional input about vaccines and patients with cancer is that even though we know we cannot assume immunity, that's the correct thing, we know that some cancer patients were included in the vaccines safety and efficacy trial. And in the Pfizer specifically, those were 1,400 patients. So this is in an oncology trial for oncology treatment will be lucky to have 1,400 cancer patients. So I think we should feel sufficiently okay with that. I want to highlight one thing that has come up since we started giving out vaccines is that there's and team, this is the slide that shows the post-vaccine reactive adenopathy. There's been case reports and anecdotes about patients who've received their vaccine and then undergo a screening mammogram or even PET scan for lymphoma issues, surveillance or something like that. And they're seeing evidence of lymphadenopathy, usually on the same side as the site of injection. And this was initially distressing because you can imagine if you go for a screening mammogram and then they see lymph nodes, it's kind of scary. So the rates are reported to be about 16% for the Moderna vaccine. And this tends to happen about 2 to 4 days post-vaccine. As I said, it tends to be ipsilateral, the same side as the injection. And it tends to last about 1 to 2 days. For Pfizer vaccine, there have been about 64 cases in the folks who received the vaccine versus 6 placebo. And again, happened 2 to 4 days post-vaccine, and it lasts about 10 days. At the time I was preparing these slides, there was not yet a reported case with the Johnson & Johnson. So this has raised the question of whether this is a class effect of the mRNA vaccine. Remember, this is the first time ever in human history that we're using mRNA vaccines. So this, stay tuned to learn more about this condition, but just be aware that it exists. Next slide. There's been a few expert opinion guidance on how to manage this, including balancing caution. So basically, if someone is undergoing screening mammogram or surveillance mammogram after breast cancer and they have this reaction, you're better off balancing caution than just assuming and attributing it to the vaccine. So do the needful, document vaccination history and site of injection. And then if someone has a history of breast cancer, probably give them vaccine on the opposite side so that it doesn't confound imaging. And then if you have the choice, probably trying to schedule screening, not diagnostic, breast imaging, maybe 4 to 6 weeks post-vaccine. Again, this is expert consensus. Stay tuned for more information. Next slide. In summary, all 3 vaccines are highly efficacious for the endpoints we care about, including severe illness and hospitalization. There is no data to suggest that they will not be safe for cancer patients. As I mentioned, pushing back about the Pfizer phase 3 trial and 1,400 cancer patients being a pretty decent size. And then be on the watch for post-vaccination adenopathy. And because we know we cannot guarantee immunization efficacy in cancer patients, should continue to adhere to public health measures, so the 3 Ws. Last section, please, Tim. So quickly, getting close here to time. This is the next slide. Cancer care delivery is a long continuum that starts with awareness and prevention in the population level to, post-treatment surveillance and outcomes in survivorship care. Next slide. The pandemic has had a broad impact on oncology practice, from managing infection risk. As oncologists, we're always balancing competing risk of death from cancer versus death from other complications of treatment or infections. Managing therapy that we know our patients need, but also the likely higher mortality in immunocompromised hosts. And we know that our medications can cause immunosuppression. Obviously, the biggest that is obvious to both patients and providers and health system is care interruptions and disruptions. There are stay-at-home orders, stretched surge capacity with often diversion of key personnel from emergency situations to emergent COVID care. And then models of care innovations such as telehealth. Next slide. So in saying that this impact has been broad, this diagram just shows almost all facets of care delivery have been affected by the pandemic. And obviously at different times of the pandemic, some have been more affected than others. Next slide.
All right, so one more poll everywhere question. Which one of the following statements about the impact of COVID-19 on cancer care delivery is true? A, the impact of COVID-19 pandemic on oncology practice is narrow and limited. B, there is a likely delay in staging and treatment initiation for patients due to the COVID-19 pandemic. Or C, no changes are expected in the development and funding of cancer trials. All right, and just a couple more seconds. Dr. Kimani, how are they doing?
Let me see. Yep.
Right.
Absolutely right.
Thank you. Thank you.
Yeah, so let me sync my slides. Yeah, so, I won't belabor the details of each of these, but there are several studies that are showing decreased rates and timeliness of preventative cancer care. This has been demonstrated for colon cancer, cervical cancer, breast, and lung. And one thing these four cancers have in common is that these are the ones with established guidelines for screening. There's also a delay in staging for folks who've had diagnosis of cancer during this pandemic, and this often includes things like staging scans or biopsies. Prolonged time to treatment initiation, and this was shown for patients who are supposed to receive neoadjuvant chemotherapy for things like breast cancer. And then some of these reasons have been due to multi-level factors such as patient factors, hesitancy to go into the hospital, health system factors, as I mentioned, the surge capacity and stretch of resources that we experience. We still don't know what the impact will be on eventual survival estimates, and there are a few studies that are exploring that. Next. So I think we can skip, actually no, let's, just for reference, there's an ASCO guidance statement on how to approach anti-cancer therapy in patients who are test positive for SARS-CoV-2. It's a long document, I can't go into it in detail. Next slide. Impact on clinical trials. There's a study that shows there's probably decreased development and funding of clinical trials, and especially impacted have been the early phase clinical trials. There's also a decreased and a barrier to enrollment as a result of the various changes that came with the stay at home. Next slide. I'll probably do this slide and the next one, and then we'll take questions. We are close on time. This slide basically shows some of the care delivery modifications. I want to highlight two of them. One is the telephone triage system, which was actually which has been deployed at UNC, was deployed at UNC by one of my colleagues, Dr. Westerman. And this was just a way to handle and interact with at distressed cancer patients. These were folks who were highly symptomatic or with high risk disease. There's also ambulatory home infusions and supportive care instead of coming to the hospital, and then virtual care and telemedicine, as we all know. Next slide. So what should we do about patients' cancer treatment? There is no evidence for interaction of targeted therapy and immunotherapy, but mixed results for chemo, as I said. So recommend individualized clinical benefit and risk. And then practices should embrace new models of care. Team, in the interest of time, you can just play the last few slides, which was just to show resources for people to look at. So those are the links for places you can find more information or stay up to date. Keep going. And those are my citations. So I think we have time for a few questions.
We do indeed. Thank you so much. The question poll is up, and so I'll be looking for those to come in. While we're waiting for the first questions to come in, and again, you can submit those through poll everywhere. It's just got to be tremendously challenging for healthcare providers, given some of the things you've mentioned, the issues with cytotoxic chemotherapy and lymphadenopathy and scans. What's some of your takeaway advice to healthcare providers who are caring for patients with cancer in this time?
Yeah, I'll say, I think we know more now than we did a year ago. So trying to stay up to date with the society guidelines through ASCO, which does actually have actionable practice changing guidance and evidence where there's any. So just trying to read on that as often as you can. And two is to have open conversation with your patients. This is equally distressing for patients as well as to the providers. And so no size fits all. So some patients might be willing to tolerate higher risk than others to balance their benefit. And so just having those conversations should be helpful. There are two questions that popped up in the poll that I probably need to respond to. One is just clarification on abbreviations, and I apologize. HR means hazard ratio, and CI means confidence interval. So it's nothing about chlorine, whoever asked that. And then for the Pfizer and Moderna vaccine, someone asked what specific normal cells take up the mRNA and express the spike proteins. That's a great question. These are the antigen, these are the professional antigen presenting cells, what we call APCs, such as dendritic cells. These are the ones that will preferentially take up the mRNA and then process that and express that protein to the receptors on top that then activate the lymphocytes, the T lymphocytes specifically, that then either do a cytotoxic response, cellular immunity pathway, or a B cell response, which is antibody production pathway.
Right, and we had a comment back to your part of the talk on lymphoadenopathy. There was a patient here at UNC with Hodgkin's lymphoma who received a COVID vaccine prior to PET. The PET showed the increased lymphoadenopathy worrisome for progression, but the follow-up imaging showed they disappeared. It was determined that the lymphoadenopathy was due to the vaccine, consistent with what you had mentioned earlier.
Absolutely, and I saw a similar case last week in clinic. So I think it's for folks in the community, this is an important thing to know, but also not to just brush it off, to do the due diligence in being appropriately cautious.
Absolutely. What immunosuppressive therapy should be avoided with the vaccines, and for how long a period of time?
This is a great question. And, I covered a lot of things, and it's hard to talk about all the various therapies in cancer. There's a paper that actually has tried to quantify the risk for each specific drug, which is just a nightmare. But the important thing to know is the lymphodepleting therapy. This is specifically things like anti-CD20 monoclonal antibodies like rituximab. We've known even before COVID-19 that those are associated with a blunted response, and therefore, if you can space them out, and a few societies have given guidelines, if you, for example, are treating indolent lymphoma with maybe maintenance rituximab, if it's okay to space it out until someone has received and completed their vaccine, that might serve them the best. But also, if you need to treat aggressive DLBCL with R-CHOP, then you should just give the R-CHOP and hope that the vaccine takes. So specifically, lymphodepleting therapy that destroy B lymphocytes. If you can try to avoid or space them out.
All right, thank you. We'll take 3 more questions. Next one, does Nccn recommend timing for vaccine with regards to starting or continuing chemo or immunotherapy?
So for chemo specifically, the chemo targeted therapy, and Yeah, for those two, when I looked at the guidelines, again, this is a rapidly evolving document that's available online. They did say that when offered, patients should receive it. So I would say if someone is ready to receive and they are eligible, they should receive the vaccine regardless of the timing with cytotoxic chemotherapy. But again, just check the document as it keeps getting updated. For some immunotherapy, there is some concern that there's some uncertain concern about safety of immune checkpoint inhibitors with the vaccination, but overall data does not seem to show that it matters. So I think the consensus from NCCN is give the vaccine when someone is eligible.
All right, thank you. For the Pfizer and Moderna vaccines, what happens to normal cells that take up the mRNA expression spike proteins? Does the immune system ultimately attack these cells?
No, so basically what happens is the biggest advancement with the mRNA technology is the use of the nanoparticle liposomal encapsulation, which allows it to be safely taken and preferentially by the professional, I keep calling them professional antigen presenting cells. And these cells are used to doing this with everything else, like with that allergic peanut that you probably exposed to. So what they do is these are the ones that present the protein through a specialized mechanism, as if to the other type of immune system. And those cells do not necessarily attack the antigen presenting cells. They form, as I mentioned, a T helper pathway, T helper 1, which activates both B lymphocytes and CD8 positive cytotoxic T cells. So the immune system does not attack the cells that have the messenger RNA signal with the spike protein being expressed as an antigen.
All right, thank you. And the last one, I think it's more of a comment, but this person says, I find patients getting chemo are hesitant to get vaccinated unless the provider tells them it's okay. I have developed a smart phrase in English and Spanish.
Absolutely, and I think that's one of the things that I was hoping to pass along here is so far, if I was a patient with cancer, I would have no reservation about taking any of the available vaccines. And so we should pass the same information to our patients.
All right, thank you. And I know a few people had to leave, but thank you to most of you for staying with us. Those are phenomenal questions from our audience and great answers, Dr. Kimani. Thank you so much. I want to say a few thank yous. Thank you to the citizens of North Carolina for their generous support of the UNC Lineberger Cancer Network and the UCRF funds through the University Cancer Research Fund and the North Carolina General Assembly. We want to thank Mary King, Veneranda Obore, and John Powell for all of their hard work on this and every one of our lectures.